practice or translate this in our own backyard. So this panel discussion would be more about how we can make POCUS happen in our regional settings. I would just dive deep and get going with some of the burning questions that we all have, because given the limitations and challenges, there are certain gray areas, uncertainties in this field, and it'll be good to listen to the panel of experts that we have today. We can pick their brains on how we approach some of these uncertainties and what solutions can be offered. I'd start this panel discussion with my first question, and I direct this to Dr. Sachin Gupta. Sachin, you're someone who do a lot of POCUS courses, and I'm sure one of the things you usually get to notice would be the variability of operators who do POCUS. I'm just wondering, as group of trainers, how would you ensure quality and consistency in POCUS image acquisition and reporting, say, in different critical care settings? It's a challenging thing to do, and I always find it daunting when you don't have set templates to go about it. Any thoughts, any tips, any tricks, Sachin?
So thank you, Dr. Ramanathan. So I would put it in two different aspects. One, you said about the training courses. So see, we have been doing training courses for last, I would say, more than a decade. And what over a decade, we started realizing that we require a set of trainers whom we are comfortable and where we can, blindly rely on the image acquisition. Some of the trainers are in this panel discussion itself. Dr. DeCosta is there, Dr. Kedar is there, where they are the, a regular feature of these courses that we do. So when it comes to I would say certified ultrasound or POCUS training courses, what we run in this country, it's a very niche trainer pool of around, I would say 15 odd trainers. Dr. Shetty is there. So we all three, probably four, are always more or less part of these training courses that we run. So, and there are a couple more. So what we know is once we are doing these training courses, what is being taught and what the image is acquired is standardized among the entire group. Now, this is as far as the training courses is concerned, or a various 2-day course or a single day course. Now, when it comes to clinical situations in respective workplaces, yes, it is difficult. Everybody will have a variability, that you understand this. And I would say it's a daily teaching program. Once, for example, in my unit, the ultrasound machine moves with me on my rounds, right? I hardly use a stethoscope. I will put it this way. Every patient has to undergo an ultrasound during the rounds every single day. It's an ultrasound examination. So, and this is where I ask my junior colleagues to keep doing the ultrasound in front of me. So I know with time what are their weaknesses, where they need to improve. So if they are saying something on an aspect which I know is a little weak in them, I would accept that finding with a pinch of salt, and I would require little more intervention, little more reading into it. When I know that somebody is very good at echo, right, and if he's telling me that this is the VTI or this is the right heart failure feature, so I would rely on that person. So this is how I practice in my hospital. It's a daily teaching program for most of my fellow colleagues.
It's more of a longitudinal assessment that you rely on rather than one step. Yeah, that's nice to know, Sachin. Any other comments from the other panelists?
Can I add something, Dr. Ramanathan?
Yeah, Rajesh here. Go ahead.
So we also have been doing these workshops for quite a few years now. It's usually 2-day course. And what I feel is that 2 days is a very short time to learn everything about ultrasound. And what they get out of it will depend on whether they continue to practice, after they go back to their hospital.
Yes.
And we never know whether it happens or not. And some of the people I've seen, they come back next year or 2 years later, and I'll be thinking,
Yes.
what is the use if they are coming back to the same course? So from this year onwards,
Yes.
we have made that, initially we'll give one certificate saying that they have attended this course. And then we have asked them to submit 50 cases. And we have divided that into cardiac, lung, kidney, certain number of cases, and send it back to us as a logbook. And we said, if you complete that 50, we will give you another certificate saying that, okay, you have completed our course requirement. And to make sure that at least some of them will submit, we have said that first 10 candidates, we will refund their course fee. We charge about 10,000 rupees, which is a big money, in an Indian context, hoping that at least some people, after they finish this workshop, will go back and practice, and hopefully, we will see the evidence of it. I don't know whether it will work or not, but this is something we have started from this year.
Sure. I mean, you've touched upon a few aspects already, Rajesh, which I was trying to bring out. I'll bring it out at a different point of time. I'll still stick on to how we standardize this. Dr. Kedar, curious to know if there is a role for standardized curriculum in POCUS. And clearly, Rajesh brought out something which I was listening. Should there be a minimum, say, number of training period that would be required before you do the certification process? Is that something which needs attention?
Yeah, so absolutely. So I think Sachin, who leads the ISCCM, and Pradeep is a part of it. Dr. Deepak Goel, Shrikant is a part of it. Dr. Shetty is also there. So yeah, we feel that there should be standardization of this curriculum, and that has been done. In fact, we have a paper on that, ISCCM paper on that.
I was
Most of
about to
us
say
are
that,
authors. Yeah. And in that we have the competencies which are defined, and how many scans you have to do, what all will be covered, how will be the reporting format. So that paper is one thing which we have published also in the ISCCM, and that really helps to standardize the curriculum. As regards how many scans, yeah, meaning when we went to our WinFocus certification, there were around 50 to 100 scans which we had to present, but not all of them were scans by Dr. Luca Neri then when I came to Pune under Dr. Pradeep's guidance that time. So it really depends on how it goes, and you have to evaluate each and every individual accordingly. So the curriculum is one thing which is definitely should be defined, and ISCCM has gone one step further to do that.
Can I add something on this?
Yeah, go ahead.
So as rightly said by Dr. Kedar, the Indian society has defined the curriculum. It is already in print. It has been printed. And on the basis of that curriculum, we have come up with the second edition of the ISCCM Manual of Critical Care Ultrasound, which is a head-to-toe. And I am proud to say that's the only manual probably where it deals with the entire body system. It's not only cardiac, not only lung, not only one organ, it's an entire organ, right from the physiology, physics, anatomy, sonoanatomy, and then we look at the airway, lung, cardiac, abdomen, DVT, and clinical case scenarios. So this is based on the core competencies. And then on the basis of these core competencies, we run a 1-year fellowship program. So when you said what should be the ideal training duration, so we are running a fellowship program for POCUS for an entire year. After the year, there is an exit exam, and once they clear that exit exam, they are certified that yes, they are at least credentialed enough to practice safe POCUS. And once they go through that entire grind of an year with all the trainers, so the trainers that are part of this panel, they're all experts in that fellowship program. They're all the teachers in that fellowship program. So this is how, because then they understand that every now and then everybody is speaking the same language, right? This is how the standardization is happening, and it's a long period. 52 weeks is not a small period when it comes to training program. And it's a very, very limited program, 20 candidates only for one complete year. Right. So this is how the ISCCM is working, and that's the only fellowship program in the world which is doing it. I'll put it on record here.
Yeah, but Sachin, just to clarify there, so it's a program that's endorsed by the Indian Society of Critical Care
Yes,
Medicine.
yes.
And are there training institutions that are credentialed for this by
No,
ACCM?
so we are not doing a contact program. So what is done is we present a presentation on one particular day. Then they have to go through that particular organ, start capturing their own clips. Then they have to present those clips in front of the group of the trainer on a Zoom session, right? Right. So they present it and then we comment on it. Is it good? Is it bad? What you're saying is there, is not. This is how you optimize your image. This is not right. And this has to be a clinical case scenario. They can't just bring me a clip and saying this is B lines. It doesn't matter to me.
Yeah.
Right. They have to come up with the case scenario, how they are doing it and what is they finding. And then we all comment on that. So this is how the training happens for a complete year.
And is there a minimum number that you would expect for the login?
We haven't defined a minimum number because we feel it's an expertise, right? Everybody will have a different learning curve, right? But once you go through that grind, you come to know that somebody requires 10 clips for an echo and somebody requires 100 clips and still they're not able to do it.
Yeah, great. I'll move on to Pradeep. And Pradeep, I'd like to bring up another usual clinical conundrum we face training somebody on POCUS. Now that we know there are training programs, credential training programs that are endorsed by societies, how do you look at, say, something like re-credentialing, say, trainees or experts for that matter, say, in a period of, say, 2 years, 3 years, how do you think the re-credentialing process should happen?
Yeah, it's a very interesting question because I would say the way ultrasound is evolving, every year or every month you learn something new. The WinFocus, which we all were a part of to begin with, has a definite recredentialing pathway in which I think after 2 or 3 years you have to do a recourse to again requalify for that basic level 1 or advanced level, or even for be a tutor in that particular session. What we find is the interest in ultrasound has reached a good level here. People are coming on their own to attend these workshops. This, however, is not a formal recredentialing. It is a sort of self-upgrading which is happening. The recredentialing, as far as I'm aware, is not yet done by any society. I'm sure the ICCM is in the process of doing a recredentialing because we have had more than 3 to 4 batches now of this fellowship in critical care ultrasound running. And each batch is a learning experience for us as well, in addition to the teaching experience. One point I would like to mention in this recredentialing is during this ultrasound course which we run for ICCM, we have also given the option of local mentors. So since the geographical area covered by the course is very wide, we usually try and group people of 2, 3, or 4 in regional geographic areas, give them one senior mentor, and then that mentor can take care of their needs. If required, they can pay a visit to the person's institution, stay with him for a few days, learn, and henceforth. So recredentialing, as far as I know, is a part of WinFocus. I am also lucky to be a part of the Academy of Regional Anesthesia. There they have a FATE and an advanced FATE program running, and that also has some sort of a credentialing pathway in place. The third pathway which I know is the Indian Association of Echocardiography, which have an exam in place for echocardiography.
But that's just limited to echo alone.
It's limited. It's limited only to echo, not critical care ultrasound or POCUS.
Sure. Yeah, it's good to know about how the training program has evolved. And we now have longitudinal training courses that focuses more on retention of knowledge as well as improvisation. I'll just move on to another aspect of POCUS here, which was again discussed by the speakers. I'll start off with Rajesh this time. Rajesh, just wondering, given that a group of people would get trained in POCUS, what medical legal implications of POCUS interpretation would impact on the intensivist. So if this were to be, if I have to put this in a clinical scenario, say a new trainee who does an echocardiogram, who misses pericardial effusion that has tamponade features, and hence the management of the patient gets delayed, how will it affect the eventual legal implications to the ICU, to the hospital? Rajesh, you're muted.
You're muted, Rajesh.
Sorry, very good question. So I was looking into, what are the litigations which have happened in India and outside India as well. And what I could see is that there is one paper as well on this, where they looked into 20 years of time, what all cases have gone into the court, and what was the conclusion of it. Surprisingly, none of those cases were related to somebody doing POCUS and making a mistake. There was only cases related to not doing ultrasound when it was indicated. Having said that, so basically there is no evidence right now to base on, what we should guide. But having said that, what I feel personally is, we should treat it similar to what you would do with your normal trainee making a mistake in non-ultrasound. And the patient family has gone to the court alleging that they should be, either doctor should be punished or they should get a compensation for it. I would say that it's the responsibility of both the trainee and the mentor to ensure that adequate examination is done and safe decisions are made, and both will be responsible for any harm which will happen. I would say that mentor probably will have to take the more responsibility compared to the trainee itself. And it is mentor's responsibility to make sure that, if you are going to allow your trainee to do POCUS, and if you are going to allow them to make clinical decisions and treatment based on their assessment, then you should be confident enough that, that can be done. And if any harm has happened because of that, it will be a mentor's responsibility. That is my view. I don't know what the other panelists will say about this.
Yeah, any other thoughts? Because, now one is in the context of this being a trainee, getting the images. I'm just thinking about a certified person. Let's say, he goes through the ISCCM program, gets certified. How would the legal implications be? Let's say if he goes wrong with the image interpretation or image acquisition. Any thoughts from the panelists?
So what, can I take this?
Yeah, go for it.
So what we generally do in our hospital is that we have a senior intensivist around the clock who again reviews the images of the junior intensivist and corrects them there and there itself, obviously. So that's one thing. But every time you may not have a senior intensivist or a person who is competent with the whole body ultrasound protocol and a teacher. So there may be lacunas in that. So you may miss out on those. So the curriculum and the training should be so good that they should not miss out on those things.
Yeah.
And another thing is, even an experienced person might make a mistake as well, isn't it? The senior intensivist on the floor can make a mistake. And I think same principle will apply if harm has happened to the patient.
Yeah, Sachin, you want
we try to run through a two-tier system or so, in which if there is some doubt in the mind of anyone doing the examination, it should be seen by an equally competent or a competent person trained in those methods, and then a joint decision is making based on 2 or 3 opinions.
Yeah, got it.
Maybe I can add one thing.
Yes. Just once again, Sachin was trying to say something.
So see, the law is very clear as of now. The law says venous access has to be put with the help of an ultrasound. Beyond that,
No.
at least in this part of the country.
Oh, yeah.
I'm not. So beyond that, if let's say I don't use an ultrasound and with the help of a stethoscope, I write there is rhonchi present, right? There is V's present. Understand it. I'm talking in a clinical sense. And I start a bronchodilator therapy. The patient develops tachycardia, goes into VT and arrests, right? Understand it. Nobody is going to sue me on that. So if I'm doing an ultrasound and I say there is mild pleural effusion, I don't tap it, the patient develops respiratory arrest for XYZ reason, right? Nobody is going to sue me that why did you not do an ultrasound or why did you not tap that pleural effusion. What I will be asked for, if I do a central venous access and I create a pneumothorax and I don't say I've done it without an ultrasound, yes, I am liable to be sued on that.
Yeah.
So we have to understand what is the legal implication. The legal implication is none as of now.
As of now, yeah.
As of now, it is none except for venous access.
I beg to differ. Just for example, I think if it goes to the court, usually they will ask an expert about what do they think, whether whatever was done is appropriate or not, and
critical care person is not. I would put it this way: they are not expected to know POCUS right now.
No, what I'm saying is that most of the people in that situation would have made the same mistake. Everyone, there is always a possibility that mistakes will happen, but is it accepted? In normal practice, will it happen? As long as there is a good system in the hospital, as you said, trainee does it under senior supervisors, or there is evidence that they've had a good training, and this expert opines that sometimes such a mistake can happen and harm can happen, but on the part of the clinician they have taken all the precautions. I think the same principle will apply with POCUS.
I'll tell you, there was a case against a senior intensivist for putting an intercostal drainage without an ultrasound guidance, and this is 20 years back. Understand it?
Yeah, that's correct.
Right, but he was not. Let me complete. He was not sued or he was not punished for doing an ultrasound and detecting that there was a pleural effusion. He was punished for doing a procedure without an ultrasound guidance. So understand the difference between these two, please.
Yes. No, what I'm saying is that there is a mistake.
Yeah, I mean, Rajesh and Sachin, I get your points thoroughly. I mean, look, I think Sachin is clear that for now we are immune. That doesn't mean that things will not change in future.
Yes.
Given that we are now starting to credential and we're giving importance to training and other things, these will take the front seat soon. And soon, we'll start facing such problems which will have to be addressed as well. Tapas, you wanted to say something in between. What was that?
I was just thinking, like, is there anything like going to be conflict between the radiologist and echocardiograpist with the intensivist? Because if we are going to do
that'd be interesting.
assessment, and then
No, I personally think there will be no conflict, because there's no conflict in what we are doing. You tell me, how many of you all can get a radiologist in the middle of the night at 1 a.m. to do an echo in a cardiac arrest patient? I think the answer is very, very few lucky people. So in fact, the radiologists probably are encouraging us to do, and anyway, we ask them to redo a scan the next day. So even if you're calculating on other means.
Yes, absolutely right. And secondly, if you ask a radiologist to, let's say, scan the chest, he would write mild pleural effusion, moderate pleural effusion, large pleural effusion, 200, 500.
Or a cardiologist will not mention the IVC.
How does it matter? It matters to you as an intensivist that is this 500 sufficient for my patient? Should I tap it? Should I not tap it? So there is no conflict of interest.
Right. Okay. I think this is really burning into a good issue, but it's good that we discuss these as issues for now. I'll just, for the sake of time, I'll move on to another burning issue that concerns POCUS, and I'd like to pick the panelists' brain on that. This, I think somebody has put up in the chat box as well. Would you charge your patient for your POCUS examination? This is something which we get to discuss even in our units in Singapore. It's considered specialized care or specialized in, modality of diagnosis. And clearly, people who do it undergo some degree of training as well. So should patients be charged for POCUS? At least in my hospital, what we do is when the echocardiographer does the transthoracic echo, the charges are different from what the intensivists do when they do a focused examination of the heart. So I'd like to know how you view this and what would be your choice. Yeah, Sachin, you've been
No, Dr. Pradeep wants to answer. Dr. Pradeep
You
first.
go ahead, Sachin, then I'll add after you.
So see, I'll tell you, I work in a private hospital. Every machine is a capex item. Machine has its own life, and the hospital expects revenue out of equipment. It's very clear. So if I'm putting a central venous line, and let's say the hospital charges X amount of money, right? How is the cost of an ultrasound machine coming out of that X, even if I use it or I don't use it? So what we do is, there is no different code, as in a non-ultrasound guided central venous access is not a code. The code is ultrasound guided central venous line, right? That's the code of the procedure. Plus, we charge an ultrasound charge as well. So we have created a code for an ultrasound. So every procedure is charged separately. So there are two codes which are being billed to the patient. A very small minuscule amount for the ultrasound, but yes, it is billed. This is for the procedure itself.
So what happens if the ultrasound gets done not in the context of a procedure? So
that's what I'm coming. That's what I'm coming to.
Sure.
Now, let's say I get a call from the ward that my patient is not doing fine, and can you just assess that patient? So I can take, either the patient comes to the ICU for assessment or we take our machine there. So if I am assessing that patient and I'm doing the scan, so we have codes, a single organ ultrasound or a focused ultrasound. So I would bill that patient. Then also that if I'm just doing a lung scanning, it's a single organ. I don't do a lung, I would say billing. It's a single organ ultrasound. Or if I say that, yes, I've done a lung, I've done a heart, and I write the report accordingly, it's just like a normal, it's just like a normal note. It's not a report which I'll be printing and giving to the patient, right? So then I charge the patient accordingly, and the hospital welcomes it.
So as long as there's an examination and there's a note following it, the patient gets charged.
The billing is done.
Yeah, Pradeep, you were trying to say something about this whole thing.
I was saying that there is sometimes a uniform charged by hospital, a per day charge maybe for a critical care ultrasound examination. And this would probably include the examinations done by all the doctors on duty, including the junior most to the senior most. Now, how the charges are divided is as per the individual institution and the individual protocols. Regarding the places where I work, yes, I also am allowed to charge for an echo report and an ultrasound report, but we choose not to do the same for many reasons. And most of the time we do it repeatedly, probably for the social cause.
I agree with Pradeep. We also do the same thing. We bill for a routine ultrasound done by the sonologist, even if we do POCUS. And same goes for the echocardiography. So if your echocardiography is done, we bill for that echocardiography. We don't bill for the POCUS unless, as Sachin said, it is for the procedure. So we definitely charge for the procedure. Even our billing process is ultrasound guided central venous access or ultrasound guided procedure for that matter.
Of course, it's a medico-legal. If it's a medico-legal situation, like maybe a trauma person or some emergency procedure like a pacing, then yes, we do give official reports because I suppose there are medico-legal aspects to this as well.
Yeah. So, Kedar, coming back to your thoughts on that. So, if your POCUS is not followed by a proper echocardiographer led echocardiography, and if you are making decisions based on your POCUS findings, would you then charge your patients?
So, yes, we are allowed to charge, as Pradeep said, but since the patient is billed already for a routine echocardiography, we don't charge for it. Because most of the ICUs have one intensivist charge already on top of the ICU charges. So that involves, generally we involve the POCUS in that as a part of our duty. And the patient is being billed already for an echo, one echo. So sometimes the patient complains that why are you charging double when the echocardiography has been done again? So each hospital or each institute has a different protocol for billing. our hospital, our hospital, we don't charge separately for the POCUS unless and until it is a procedure which is guided with POCUS.
So there's clearly some variability in that as well. I mean, I heard Sachin say that, he would charge his patients if it is required for a POCUS, while, Kedar, your answer was somewhat exactly 180 degrees. So clearly, we can clearly see that there is a lot of variability in our practice. And even when it comes to things like costs, we do have our own institutional policies. These are probably not things that would change overnight. And I'm sure, as we do more and more POCUS examinations, we would start thinking about our workload, we would start thinking about our expertise being used. And I'm sure, at some point, we will then start thinking about cost effectiveness of such interventions. So, yeah, I mean, I agree, that this is something which is variable and this cannot be standardized or, made uniform overnight. I think we are coming to the end of the talk. We've clearly had a nice 30 minutes or so discussing the various administrative aspects of POCUS. Clearly, the technical aspects of POCUS were highlighted by the speakers. Sometimes, the administrative aspects can be more daunting, and it can take a lot of your time sorting out with the individual patient. Anyway, thanks. I thank all the panel members for your thoughts and your insights into this great talk. And clearly, Tapas, a great thanks to you too for getting this on board alongside a webinar. And I think this is something very important in the current age, to at least be aware of certain gray areas and issues that surrounds POCUS in critical care.